there it is. Share now. Window. Let's see if this works.
I also have the slides pulled up if you want me to share them, unless you had already had edits made.
I had so few edits. It's not letting me share without like backing out and going into my settings to redo it. So maybe you can share and then I can tell you the few things that I sort of saw as we flipped through them, I guess.
Okay.
I hate when it does that. You don't know till you're in the meeting that you have to shut down your whole computer to do some sort of.
Okay. Can you see that?
Yep.
Okay.
Okay. So this presentation, I'm sure Brian has seen this one before. Eric, I don't know if you've seen this one before. This was put together probably several years ago now. And really the goal of this work group is to make any necessary updates to the slides to make sure that things are current and don't need to be edited at all. So generally on these review slides meetings, there aren't a whole lot of changes always. Hopefully this doesn't take us a terribly long time to get through this. So if you do see something as we go through, we can kind of talk about it. I'll highlight the couple things that I saw. Okay, I guess you can move on, Julia.
I'm going to scroll through the slides.
Yeah, we'll just kind of go one at a time.
Okay.
I still see the first slide, Julia. Did you scroll yet?
Oh, sorry, on the objectives.
I don't see the objectives. I see the title slide still.
Is it like doing the slideshow?
No, I see your sidebar with your thumbnails. So it looks like it's not in any kind of presenter mode.
Weird. Can you see it now?
Yep, now I can.
Okay, I can't change anything in this, but we can just read through it. And then if needed. Okay.
Okay, and then can you make it a tiny bit smaller? I'm seeing it cut off a little bit on my screen. Your slide size. Like zoom out a tiny bit.
No, I'm feeling technologically challenged. Let me see. It's not really scrolling out because it's. I wonder if I put it on this screen, it'll be smaller.
And I can see it now, but now now you're on a different slide.
All right. All right. Here. Are we back to objectives?
Okay, there you go.
Okay.
Okay, cool. Hi, Brianna. Thanks for joining.
Thank you, Amber. Hi.
Okay, so on the objective slide, I don't have any significant changes. I mean, we can talk about, it's not really the protocol refers to the TTTG that we have in there. So I think maybe I could change that just to say the sepsis TTTG, just to be more like accurate, I guess.
And the last bullet.
Yeah. It's so weird. My slides are like, it's not even letting me edit them.
I can.
Let me see if I can. It's really weird.
Well, I can make some notes. Understand sepsis TTTG protocol. Just add that.
I think you have to leave the slide view to be able to do any edits, right?
Yeah, I can't edit right now on screen. I don't know.
It's just weird. Even on my computer, though, working on a different screen, it's not letting me. It's the weirdest thing. Yeah, I don't know what the deal is. I don't know, Julia, do you want to try to go back to?
Let me just try again. Oh wait, is it on the objective slide on your screen?
Yeah, that looks good.
Okay.
That looks like it's supposed to.
Yeah, I don't know why it's not. So odd.
This one almost looks like I can't tell what's going on with this specific slide, but on my computer, it doesn't let me edit it any
It's
other way.
not letting me edit either. I'm just gonna write on the
Really?
bottom in the notes section.
Yeah, that's fine. Let me just have to retype this slide. Because the other slides are letting me go in and change them.
Yeah, it's weird.
That's super strange. Okay. I don't know. Any other thoughts about the objectives? I think they cover things.
Next slide.
This one's just a funny picture. So obviously when anyone downloads this off of the ADHS website to use, they can add or delete things as they see fit, but
Did we want to update anything down here? It's a little bit probably hard to see right now, but
I don't think so.
okay.
I could maybe update the stats in terms of mortality. Hmm.
Okay, so maybe an update there, but not necessary.
Yeah, I think it might be like slightly outdated, but I don't think that it's.
Okay. All right. Anything else on this side?
I don't think so. Now it's 1.7 million. Get sepsis a year, if we care.
Oh, from 750,000 to 1.7.
Yeah, I don't know. I mean, looking at this thing, third leading cause of death. Oh, wait, here's WHO. It's worldwide. There's the CDC's numbers. Um, yeah, I can find his mortality numbers, but yeah, I think we can leave it.
Okay.
The last numbers I see here from even CDC are through 2012
Mm,
for some of their stuff, or no, 2019 for some. So it's not super new data anyways.
Okay.
Okay. And then the next one, I think it's just another info slide. This one, the bottom talks about just talking about the overactive immune response causing inflammation. When sepsis is recognized early, people can quickly give the right treatment. However, signs and symptoms can vary and be subtle, which can lead to being missed if it's not considered early on. It's just a general blurb at the bottom. I think it's fine.
okay.
Right, next one. Do you guys just tell me to stop if you guys want to stop and read more or address anything? Just tell me to stop. Okay, you can go to the next one, Julia. Defining sepsis. Go back up to that one a second, Julia.
Is it on the defining sepsis slide on your screen?
Yeah.
Okay.
Yeah.
Back up to the one before that.
No, that's all good.
Okay.
I don't know if this is a particularly helpful slide. I don't know. I don't know. I don't think the slide tells us much, but I don't know what you guys think.
I would agree, because dysfunction isn't really defined really well. Just my 2 cents.
Yeah, I mean, I kind of get what they're trying to say here. I think they were trying to be vague probably and not. But when I think about, I mean, the definition of sepsis. I mean, this one is, like, if I read from what the CDC says, 'cause there's just sort of plain language. Sepsis is the body's extreme response to an infection. Sepsis happens when an infection that you already have triggers a chain reaction throughout your body. Actually, it doesn't sound terrible. I can put it in the chat, Julia.
So the CDC definition.
Yeah. And then that. Like these could be the bullets. They might be a little more.
Okay. Oh,
I don't know. What do you guys think about the
Yeah.
rewording that slightly?
I think that's better.
so replace these 3 bullet points with this CDC definition.
What's that?
So replace the bullet points with the CDC definition.
Yeah, I mean, it kind of says the same thing, but I think this slide's a little confusing. Dysfunctions that progress together in a predictable way, but then we're saying it's a variable clinical presentation.
Yeah.
This seems kind of, I don't know, it doesn't really read super well to me, but.
Okay. Okay. Make that look nicer.
Yeah.
Um,
Okay.
Hmm. Amazing.
I think that one's just. I don't know if we need this slide. What does that say at the bottom?
It says multiple celebrities have died, including Christopher Reeve, who portrayed Superman. Jim Henson passed away from sepsis from pneumonia. Muhammad Ali died from sepsis.
I don't know if this is helpful. Very random. I think I had that one as the suggested one to delete just because it was kind of out of left field. Like,
Anyone else have any thoughts?
No, I think that's fine.
Okay. Delete slides. Actually, I could just delete it.
Yeah.
Okay.
I don't know. I think the slide's good. Just kind of shows that you compare severe sepsis to other things like even STEMI and stroke, the mortality is extremely high. I don't have any like reference to this data though, so I have no idea where this data comes from.
Yeah, a lot of the information here doesn't have a source, which is hard to, follow up on.
Yeah. Let's see if there's. I don't know if someone just made that up. I don't know. I can't find a. Oh, here we go. Nope. That's.
Mm.
To find one that's like a real actual data source.
Is there maybe a reference at the end of the presentation?
No, there's none.
Good question.
I mean, I could probably find one somewhere. We could keep moving on, Julia, and I'll keep looking for a better data slide.
Okay.
Oh wait, here we go.
Okay.
Oh yeah, here we go. Here's a better one, but it comes from. But their numbers look very different. Like they have AIDS, breast cancer, AMI, and sepsis, which are the same. And in our slide, we have STEMI as being very low compared to severe sepsis.
Hmm.
So I don't know. I think we should maybe put a question mark on this slide, and I'll look for. I'll put together something that's got some like updated data in it from the CDC.
Okay. Sounds good.
Make a note for that one. I'll make a note on my slides. Updated data. I'll just pull actual data and just make a table.
Hmm.
Yeah, I hate to put something in here that's like not true. Okay, we'll move on from that one and I'll make a better data table to replace that.
One, I don't know if it got a little messed up in
It probably did. Mine looks very different.
here. It says, okay.
Yeah, mine looks like it's got like four boxes, and it's like a kind of like a flow chart. Actually, it looks fine to me.
Okay, it's probably just because I opened it in Google, I'm gonna guess.
Yeah, but it kind of says the same thing. So it makes it look like there's a spectrum. So it just goes across the screen this way.
Okay. Any changes needed?
I don't think so.
So I do have one question there.
Yeah.
On the SIRS, it says low PCO2 without a number, and there was a study that was done that went together with the sepsis alert system that Orange put together, that if you have a PCO2 of 25, it correlates to lactic of 4. But that was the definition of, I think, sepsis, not necessarily SIRS, but there's nothing in there. It just has 2 SIRS criteria, but the Orange County had 2 of those plus an end-tidal CO2 of 25 or less.
Yeah, so in the later slide 45 in this set says low end-tidal CO2 associated with high lactate. End-tidal CO2 of 25 is a lactate up to 6.1.
Okay.
Low end-tidal CO2 predicts mortality. That was later in the slide set when it talks about like septic shock and stuff like that. So we do have that in there without defining it here. Do we want to put something? We could be more specific in this slide where we say, oh my gosh,
there are different groups that have come up with the criteria as to how that works. And so I'm just going, the Orange County criteria at one point in time just kind of seemed to be some of the better literature at the time, but
yeah,
that may not be the case today, and maybe too specific. I think the next slide covers that part anyway.
Yeah, I think it does. And this one has PCO2, which we're never going to have in the field. And end-tidal CO2 is just like a sort of guess at the PCO2. Okay, do you want to go to the next one, Julia? Good question, Brian. And this one's, yeah, kind of the same thing. This one sort of defines the PaCO2 less than 32, which is sort of the traditional in-hospital cutoff for SIRS. I think this kind of says the same thing as the slide before it, in a way. Yeah, I think their slippery slope thing was just meant to be that you're, just because you haven't reached the septic shock part yet, if you're severe sepsis, you're probably on your way to septic shock. Yeah, I don't have anything else for that slide. So this one, local infection, non-specific inflammatory response, and then 3 phases. So that's like the normal response to infection. And then the slide after that's supposed to contrast with it. So if you go to the next one, Julia, yeah, the pathophysiology of sepsis. So this one's just saying that this one's not such a controlled immune response or localized response, that it's uncontrolled and exaggerated. And that we end up with a bunch of damage because it's out of control. So that the systemic inflammatory response is, as opposed to a localized inflammatory response, I guess. That's probably what they're trying to get at here. I don't have any issues with this one.
Okay. Next slide.
Yep. This one, the bottom talks about how there's multiple infectious causes, multiple triggers for SIRS. And once you identify systemic inflammatory response, you must look for the trigger. And basically showing that SIRS and infection overlap in the middle with sepsis. So I think it's just a visual way to look at different things that can cause a systemic response. So I don't have an issue with this one. The next one is basically defining SIRS. It says in here, EMS uses a version of SIRS. I don't know that it's EMS per se, but our guideline uses a version. But I guess we could leave it at that. But there's not like a specific pre-hospital necessarily SIRS criteria. We just have adapted it. But I don't have an issue with it. These next couple slides, I did have some things to say about, but so this one, this first risk factors for sepsis, I think this slide is fairly helpful. Extremes of age, recent surgeries, reduced immunity, those things I think are very true. The next slide, I was one that I had flagged for potentially deleting because I thought it was a little bit confusing, or maybe too in the weeds, but I don't know. What do you guys think? Like, I think these things are true, but there's 2 slides of this. So Julia, if you go to the next one too, there's essentially like 2 slides of increased risk for sepsis, like listing a whole bunch of things. I don't know. What do you guys feel about these
I
lists?
don't know, maybe cut it down to one. Like the diabetes one, obviously that's important because they've got it written 3 times in
Yeah.
capital letters, but figure out which ones are the most maybe just more specific to sepsis as opposed to other other things.
Okay.
I don't know what I'm trying to say.
Mhm.
Like recent antibiotic use, I don't know, indwelling catheters, that would probably be important. I mean, just things like that. It's pretty busy 2 slides.
Yeah, I agree. I would like to at least cut it down.
Are there certain ones we can just take off right now?
I mean, I think you could combine a lot of these: liver cirrhosis, autoimmune diseases, HIV, sickle cell, splenectomy patients. I mean, we're just not going to know these things a lot of times. I think all of those could be combined into something called like chronic diseases or various chronic diseases or something like that, and get rid of the list of all of those that could be combined into being just having chronic disease makes you more at risk of infection in general. So get rid of like cirrhosis, autoimmune, HIV, AIDS, sickle cell, splenectomy. I think all those could probably go. And then the next page, maybe keep indwelling catheters and chronic steroids.
That sounds good.
I think the rest are sort of
And maybe chemo.
chemo. You want to keep that one, Brian? Yeah, I'm okay with that.
So
Yeah.
Wait, oh, delete this one, post organ transplant too.
Yeah.
Okay.
Yeah, I think I had cut those down. I had a slide that I had made that said, who is at risk? Adults over 65, people with chronic medical conditions such as diabetes, lung disease, cancer, and kidney disease, people with weakened immune systems, recent severe illness or hospitalization, and children under 1. That's what I had typed out on my list, but I think what we have is fine. I think that's better.
Okay.
Thanks, Julia.
would maybe some down in the notes, maybe some list of some of those be appropriate instead of being in the slide? Have some of those various chronic things that were listed on there down in the notes.
Sure, I could do that. Julia, I'll
They can,
pop
whoever,
it in the chat, Julia, so you can copy and paste it back.
Good, thank you.
You want to just paste it in the notes? Oops. And just put the complete list in the notes.
Mhm.
Thanks, Brian. Okay.
Okay, delete this.
Perfect. Signs and symptoms of sepsis.
On that, maybe I like the fact that the little blurb in the bottom that says patient often does not appear acutely ill is good,
Mhm.
but maybe highlight just a thought. symptoms of sepsis are often nonspecific. Maybe highlight that area, because if you look at all the signs and symptoms, that could be COVID.
Mm-hmm.
But if you just, I think the point we're trying to get across on this slide is the symptoms are nonspecific and people aren't necessarily critically ill.
Right. Exactly.
You know, and
Mm-hmm. So highlight the word nonspecific or underline it maybe.
yes, something like that.
Yeah,
Just
okay.
to make sure people know it mimics a lot of stuff.
Yeah. Or maybe just underline it, Julia. Mm-hmm. So do you want to put something like that in the notes, Eric? Something that says like symptoms may be seen in other,
Yeah.
or these may be the same symptoms seen in other. Trying to think of,
Other illnesses, whatever
Yeah.
conditions, something along those
yeah,
lines.
or other conditions. Yeah, that's a good one. Mm-hmm. Okay, thanks, Julia. This one, I think, just describes what we mean by multi-organ system dysfunction. So these are the things that you'd see in any of these organ systems. So I don't have any issues here. Causes of sepsis. I think this just highlights the lots of different ways you can get an infection. Anything here? Nope. The only thing I suggested striking from this next slide was, not that one, Julia, sorry, the next one. So I think most of that is correct. I think saying care bundles monitored by feds, I think that doesn't really, monitored by feds is just means that we have, you know, guidelines in the hospital that we're held to. I don't know that it has any meaning to EMS that the federal government or these different agencies are monitoring sepsis protocol use in the hospital. So I don't know. I suggested just striking out monitored by feds and just keeping it at care bundles. The rest is pretty true, I guess.
So remove monitored by feds.
Yeah, I don't think that is clear what that means necessarily in the pre-hospital world. This is it's really an in-hospital thing, but yeah, care bundles, which is true. Okay.
Can we go back to the previous slide from that?
The
Causes of
causes of sepsis, yeah.
So, isn't this kind of a repeat of that other slide we had with all that stuff listed on it? Or was that only about infection versus sepsis? Because it seems like this is kind of, I don't know, redundant in a way. It has other stuff that's listed that maybe is a little more specific, I guess, but I don't know that that's
Yeah.
as important as, you know, having indwelling catheters and things like that in there. So
Yeah, I mean, it is a bit redundant for sure. That one was risk factors for sepsis, and this one's causes of sepsis when I go back and look at the other slide.
well, okay.
But I don't know. I mean, I don't have very strong feelings about keeping this in at all. I mean, this really just lists different types of infections you can get. I don't know that it's particularly helpful. So if we, I mean, if we feel like we should take this one out, I don't have a lot of heartache over just listing random infections. It's really kind of all this is a random list of things saying that they're,
Right, yeah.
I don't have strong feelings about it. I don't think we have causes of sepsis anywhere else in the slides. The other one's kind of like risk factors for developing sepsis from an infection. And this one would be specific causes or infections that could lead to sepsis.
Yeah, I feel like I interpret it a little bit differently. 2 slides.
Yeah.
That's fine.
Fine to keep it in.
Yeah, I think so.
Right. Okay, we removed that.
Yeah.
It's still true that many hospitals around the valley administrative leaders are educating all those in contact with these patients with posters, videos, lectures, etc.
Yeah, I would say that's still true. This is still something we do like all the time. We still have every patient in the lobby that's got an elevated heart rate, I get a page about. So I think they're very much still doing that. This next one, I think it's meant to show obviously the mortality goes down, survival goes up. Obviously, the faster you get antibiotics on board. And it's one of the most important factors. So I think we could talk about that because I think it does lead into the slide after it, even though this is a sort of hospital-driven metric.
My only concern with this slide is it's from 2006, and I'm just weird about dates and most current stuff. So I don't know if this is still true or not in 2024.
Yeah, it
It needs
definitely
to be
is.
updated.
Yeah, no, it definitely is. This is one of the first studies, this critical care medicine article that showed this. I think it's fine to leave this in because it's sort of a landmark article. But I mean, I can look for something newer, but this one very much is still
No,
true.
it's good. It tells me I'm going to be the only person that notices it's 2006, so it's fine.
Yeah. I will look, I'll add that to my list of things to look and see if there's a newer, better looking one. There probably are newer articles that show the same thing. Okay, Julia, go ahead. And I'll put that on my list to find a new picture.
Okay. This slide doesn't have anything, but there is a little bit of text in the notes section if you wanted to.
This one just talks about more rapid administration of the care that's in these care bundles and the assistance it gives to the emergency department. So they've gotten some of these things before they even get to the ED. That's kind of what they're saying in that bottom, which I think is fine. This one is a handful of articles. There are some newer articles. That show sort of similar things, but are newer. So I think in this slide, there are 5 or 6 articles they highlight.
Yeah, there's a bunch.
So there are about 5 articles in here. that kind of show different things.
Do you want to look for new ones or just?
What do you guys think? I mean, I'm totally happy to put in some newer articles in here where it's relevant. Because certainly these are somewhat out of date. The Henry Wang paper is probably kind of new. When is that one from?
This one's 2014.
Yeah, the Henry Wang one's relatively new.
2010.
Yeah, I mean, I think we could definitely maybe replace one or two of these with something newer.
Okay.
I don't know. What are your guys' thoughts?
I think unless there's, unless there's other stuff that really significantly changes what they're saying,
Yeah.
it probably isn't worth it. If there's something newer that, would really change the way these are looked at, then that might be one thing. But
yeah, I don't think that any of this has changed in terms of newer literature, sort of reversing any of these things. Most of the literature shows the exact same stuff.
I think maybe adding one newer article might just make
Yeah.
it apparent that we at least looked. I don't know.
Yeah. Yeah, I can look for that too. So I'll kind of come up with some new literature I can I can throw in. And then what I'll do is I'll have to ask Shelley, but I think I can send it around offline. Can't I, Julia?
I think for this, yeah, because we're not
It's just
voting on it until the actual meeting. So I think
Okay.
for this.
Okay. So yeah, maybe I'll throw some new stuff in and then I can send it back around to the group and folks can just look at it offline and give some feedback and rather than meet again. So yeah, so I think that in the end, I think what they're showing in their, if you go past this, Julia, to their summary, just showing that EMS, if we have a way to recognize it, we can decrease the time for them to get fluids and antibiotics and decrease their mortality and hospital stay. So I think these are sort of all the reasons why we care. And then it moves into identifying sepsis. So how do we identify it? So it's basically looking for sources of infection, looking and asking about risk factors. And check a temperature. And then in the next slide, it kind of goes for, it's kind of the same thing. Looking for SIRS criteria in the vital signs, shock and dehydration, and check the end tidal CO2. I don't have anything to add here. And then treatment, it's obviously keeping, providing airway, IV access fluid boluses, which I think is what's in our TTTGs. The only other thing that I might add to this, Shelley or Julia, is the, like we talk about fluids, we don't really talk about pressors in here at all. So there's no other treatment slides in this, so I think that maybe adding a bullet about using pressors is needed for shock. I don't know what you guys think, but
yeah,
we don't have that in here anywhere.
I have another question. Didn't that 20 change to 30 now?
Ooh, let me check.
It seems like we made a change in the TTGs on that, but
Your memory is usually better than mine, Brian. Hmm.
Because I know we're using 30 here now, and it seemed like we made that change for
Mm-hmm.
because it come up at the state too.
I have 20.
It's
I'm wondering, am I looking at the right ones though? This is what I'm wondering, because we also don't have pressers on here. Which
Well,
I think can't be
I would
right.
like there should be a line for paramedics with norepinephrine and stuff then.
There is, but push dose epi isn't on here for shock. So this has to be like a different version that I'm looking at. I just typed it in. Oh, that's 2020. Why is 2020 coming up first on the Google search?
Hmm.
There we go. Okay, so now I'm on the current version and it says 30.
Yeah.
Yeah, so we'll need to, Julia, maybe screenshot and replace the TTTGs, obviously. Yeah, and then when I click on shock, now it has the push dose epi. There it is. Okay, and I was like, what the heck? Why isn't any of this? I was Googling and getting the wrong version.
Well, it's good to know that the old one comes up, which must
Yeah,
be.
if I type in Arizona TTTG, the first thing that comes up on my Google search is the 2020, and the one below it is the 2023.
Okay, good to know.
Okay, so anyways, so yeah, so we'll screenshot and replace the next slides too.
Yeah, okay.
And then sepsis alert, I think this is fine.
Okay.
And then this is this, and the next ones are the screenshots that we'll have to replace. And then I think they have it kind of blown up on the next couple slides. I don't think that one changed at all. Yeah, that one did not change.
Okay.
I don't think anyways.
Oh, wait, all the same
I don't think that.
shock. Okay. Let's double check. Okay.
And then the only other question I had in this one is that one. This is the next one. I don't know if this slide is helpful. I think it's technically true, but I don't want folks to think that if all they have is dopamine, that they shouldn't be using it.
Well, I'll tell you, I have a, I don't know of a single EMS study that shows dopamine used initially in the field. That's all critical care medicine literature about dopamine and tachydyspnea is causing
Right.
mortality. And given the fact that when we added norepinephrine to the drug box list, it was required to be used with an IV pump, which
Right.
lots of places don't have to limit that to dopamine when they can get switched to norepi when they get to the hospital.
Right.
I don't like discouraging that either, to use that when you need to use it.
Yeah. Because I don't know that it's true to stick with fluids in rapid transport if someone's in shock.
Right.
Like, I think if you compare head to head norepinephrine and dopamine, like, yes, I think that there's something there, but dopamine versus nothing, I don't know that that's. Yeah, I can't find it. I've never seen a study that showed that dopamine was worse than nothing.
I think that line needs to go away. The thing I'm wondering is if we can kind of build these lines around the norepinephrine requires an IV pump in Arizona in field use, and many agencies will only have dopamine when fluid boluses don't work or something like that.
Yeah, maybe we just change it to a slide about pressors generally, Brian, and not make it focus on dopamine.
Well, that could be true too, because you know, we use a lot of push dose epi up here for different things right now, especially on shorter transports, than trying to mix more epi and hook it up to a pump, even for those agencies that are lucky enough to have pumps on their rigs.
Yeah, and we had the slide before the TTTG added the push dose epi in, right? So I think that with the change in that, we show them the slide that says, here's how you treat shock. And then we show them a slide right afterwards that say, don't do that. So, I mean, I think that we shouldn't contradict what we put in the guideline in the slide before, which says, if you've given them fluids and they're not responding, then you need to start whatever pressors you have.
Right. Yeah.
Yeah. So I think we either delete this or we just make a slide that's just a slide that discusses the use of pressors. You know, you could say, maybe we have a slide that says, shock unresponsive to fluid administration or something like that.
With the options. I would like to, and I think getting rid of this slide and doing that instead with
Yeah.
that slide would be better.
Yeah, because this definitely contradicts the TTTG.
Yeah.
So maybe delete this one, Julia.
Right.
And then we'll add a new one in that says treatment of shock in sepsis. And you can just put a new slide in, Julia.
Okay.
And then we'll just kind of lay out, obviously, what's in the TTTG, which I think is if I could just copy and paste it. Let's see. Well, here we go. Maybe I'll just, I think if you just copy and pasted what's in the TTTG, so it's going to basically look like this.
Shock. Okay. We'll figure that formatting out.
Yeah, but I would just maybe paste what's in here. And then do you think we need a slide about mixing up push dose epi?
Well, I don't know. I mean, we have it kind of a little bit in our treatment guidelines, and then we've sent out a video we got on, you know, how to mix it. But
Yeah.
I'm hoping that people have got that worked out by now for those who are using it.
Yeah, I would think so. And obviously you would just edit the slide if it didn't apply to your agency. Yeah, something like that. We'll reformat.
Cool.
Yeah, I like that.
Okay.
That's definitely better.
I'll fix the highlighting.
Okay. And then in this slide, the question I had for the group was, it says respiratory component of sepsis, mismatch of oxygen availability and demand, essentially. It says keep SATs above 92%. I feel like in most of our other guidelines, we say 94%.
Right.
So maybe we should just keep it consistent. I don't see a reason to make it 92 and not 94 here.
I think there's an earlier slide where it said that too somewhere.
Oh, did it?
Earlier, yeah.
There might have been. Let's see if I can find it. No, I only see this one.
Okay. I thought I saw one earlier that said 90. too also, but
that's all I had in this one.
We have 5 minutes on our scheduled time left and about 5 slides. Well, actually 4, so I think we're good.
Yeah, I think we're fine because the next ones are just summary slides. And then this one, I didn't have anything for this one. And then this one, I had a question. Pitfalls. Beta blockers block tachycardia response. That makes sense to me. Altered mentation not recognized as organ failure. Temperatures not checked. End-tidal CO2 not checked or recognized. And I don't know what this means. Discouragement due to hospital response. I'm not sure how that means.
I'm guessing it's just maybe, oh, go ahead, Brian.
I think it's this discouragement on the EMS providers part because the hospital won't do sepsis alerts and things like that.
Oh, okay.
Exactly. That's the way I read it too.
Okay.
So they don't follow through. As a result, they may not follow through
Got it.
on it.
Okay.
I don't know
Okay.
different way.
No, I think that makes sense to me. I just I think now I get it. I think that makes sense to me. And then the last slide is just the end-tidal CO2 and lactate thing, which is, you had kind of talked about this, Brian.
Yeah.
And so versus using a PaO2, like obviously what we have is an end-tidal CO2, but knowing that, I think what people need to know is it's end-tidal 25 or lower. The 25 or, I mean, depending on how you read that.
Well, in one of the studies I read when we were working on ours here was the 25 millimeters was related to a lactic of 4. So of course, if you're less, it's going to be more. And I did find that I did follow up on that reading what we got here with our first blood draw, and it was pretty close.
Yeah.
So
yeah, I think it probably just depends on the study that you look at specifically, but oh yeah, you did find it, Julia.
Mariel did. Thanks, Mariel.
Yeah, thanks.
Sure.
Okay, so do we need to change anything on here? I mean, I think it's okay.
yeah.
And then that was pretty much the end of it.
We
We did it.
Yay. What is the point of this slide?
I think it's just the summary.
Okay.
I think it's the same as the title slide.
Yeah. Okay. Okay, cool.
Yeah, and then the end slide, which is the normal DHS one. Okay, well, I will plan on adding those like literature, see if I can find some updated literature sources to kind of plug in a couple of these places, and then I can send it back to you, Julia, to add in, and then maybe you can send it to the group and for some offline feedback and make sure everyone's like okay with the changes before we send it to the education committee.
Yeah, for sure. I can make all the changes look nice and then send them out to the group. And
Okay,
awesome.
that would be perfect. All right, I don't have anything else from you guys. If you guys think of anything else, obviously Julia will send it back out again for feedback once I put those new slides in. So if you catch anything else or need, have any other burning desires, feel free to let us know.
Sounds good. Thank you, doctor.
Thank you guys for joining. I appreciate your help.
Yeah, thank you, everyone.
Thanks, Julia.
All right. Bye.
Okay, bye.